All right. Well, welcome everyone. It is time for the latest edition of National Journal Club. And I would really like to sincerely thank our colleagues from Rutgers MedTox program, led by Dr. Gina Jacob, who's program director, along with fellows David Logren, Christopher Meaden, and Mohammed Jeffrey. So with that, let me hand it over to Gina.
Okay, thank you, Steve, and thank you everyone for joining. So today, for the next hour, we're going to be talking about alcohol withdrawal and some recent modalities. And the reason we picked this topic was because it's a very important topic, not only because of the magnitude of it, the problem, but also because there have been some recent articles that have reviewed and studied some non-traditional therapy. So we thought it would be interesting to discuss that in this forum. So with that, I'm going to hand this over to Christopher Meaden, who is our second-year fellow.
All right. Thank you, everyone. If we go to our first slide. And we will be first starting off with an article from JAMA Internal Medicine outlining the efficacy of gabapentin for the treatment of alcohol use disorder in patients with self-reported symptoms and diagnosis of alcohol withdrawal symptoms prior to being started on this therapy. Some background on the next slide shows that less than 1 million individuals actually receive any medication to help maintain abstinence to reduce alcohol intake. A large reason for this is that there's no great MAT like there would be for buprenorphine in the setting of opioid use disorder. And only 20% of patients who would benefit from treatment with alcohol use disorder actually receive any treatment whatsoever. And then 20% of that are started on some level of medication. So it's really a small grouping of people that's getting medication to assist them with alcohol use disorder. Alcohol withdrawal, as I think all of us know, has some difficulties or different nuances in management, and that's largely due to variation in how it can present, and some of that actually might be genetic in relation. And as I think we all know, withdrawal syndrome in this setting is mediated by the GABA glutamate brain signaling system, which is different from the reward system that makes drinking pleasurable, which would be separate based off of dopamine brain signaling, as well as release of endogenous opioids. Gabapentin specifically is unique in the sense that it binds to voltage-sensitive calcium channels, which affects their function and influences overall receptor trafficking, leading to secondary influence on the GABA glutamate activity, so important for alcohol withdrawal syndrome. Prior studies have actually shown gabapentin to be efficacious for the treatment of acute alcohol withdrawal, and also in providing short-term relapse prevention after medicated alcohol detoxification. There's also been some recent RCTs looking at gabapentin's use for alcohol use disorder. However, these never really took alcohol withdrawal symptoms into account, which leads us to this study today. So on the next slide, we can see the objectives from this group. And what they were really looking at was to examine whether gabapentin would be useful in the treatment of alcohol use disorder in outpatient individuals who have current or historical alcohol withdrawal symptoms. Secondarily, they looked to evaluate the relationship of recently experienced alcohol withdrawal symptoms to gabapentin response, with the hypothesis being that gabapentin would be more efficacious in those with higher levels of self-reported alcohol withdrawal symptoms. Next slide. So in order to do this, they constructed a double-blind randomized clinical trial. It took place between November of 2014 and June of 2018, and it was looking at gabapentin versus placebo during that time. Within that time, these were all community recruited participants, and they were screened and treated in an academic facility, and the treatment period was 16 weeks where they would undergo treatment with either gabapentin or placebo. Next slide. So to be included in the study, patients needed to be between age 18 to 70 years old. They also had to meet DSM-5 criteria for alcohol use disorder, including alcohol withdrawal. They had to have a minimum of 5 drinks per day within the last 90 days. And they also needed to be abstinent in the last 3 days prior to randomization into placebo or gabapentin group. They also were not allowed to have detection of other psychoactive substances in the urine. On the next slide, we can see exclusion criteria, which included use of psychotropic medications, with the exception being antidepressants that were at a stable dose of 1 month or greater, and then meeting DSM criteria for major depressive disorder, bipolar disorder, eating disorder, and psychotic disorder. They also could not meet criteria for other substance use disorders, with the exception of nicotine. They could not be medically unstable, and their medical instability actually also included, so if their liver enzymes were 3 times greater than the upper limit of normal at the institution, they were deemed as being medically unstable and excluded from this study. They also could not be pregnant or breastfeeding women, and they could not have significant alcohol withdrawal, meaning a CWA score of greater than 10, or alcohol withdrawal seizure within their reported time of alcohol withdrawal. On the next slide. So the intervention that they received, so after this 3-day abstinent period, they were randomized into their groups for that 16 weeks of treatment, which was given to the patient via blister pack. The treatment course overall was day 1, they would receive 300 milligrams at night of gabapentin. Day 2, they were started twice a day on 300 milligrams of gabapentin. Days 3 and 4, they received 300 milligrams 3 times per day. And then day 5 through day 112, they received 300 milligrams at morning and noontime, and then 600 milligrams in the evening. The medications were additionally over-encapsulated with riboflavin, and this was so that the study group could measure adherence to the gabapentin. And before they were randomized, they were also underwent multiple assessments, including multiple different symptom checklists and diagnostic scales for alcohol withdrawal, as well as obtaining baseline labs. And then lastly, the patients underwent medical management, which was conducted on the weeks as displayed here. And at that time, they were also assessed for medication adverse effects using a systemic assessment for treatment of emergent events, or a safety score. Next slide. So their overall outcome measure, primary outcome in this study, was percentage of participants with no heavy drinking days, where a heavy drinking day is defined as 5 or more drinks per day for men and 4 or more drinks per day for women. And these were, of course, standard drinks. Secondary outcomes were the percentage of participants with complete abstinence or no drinking days. Their patients in the study were also confirmed, so their verbal report was confirmed by looking at a percent DCDT, which was used to actually measure if there was significant heavy drinking going on. So if the percent DCDT was greater than 1.7% at any time, this was considered to be heavy drinking and not abstinence. On the next slide, you can see the consort diagram. And initially over the study period, 145 individuals were consented. You can see those who were excluded here, ultimately leading to 96 individuals being randomized. In order to reach an appropriate power, the group did calculate that they would need approximately 45 participants in each group to reach power for statistical significance. And you can see that of the 96 individuals randomized, 46 were randomized to gabapentin, 50 to placebo. However, in the end, 44 participants that were ultimately analyzed, there was a dropout rate of 13. And then in placebo group, there was a dropout rate of 18 of the 46 randomized there, with the rationale given in the figure. Next slide. So in table 1 in this study, the group reports all of the population demographics. And the take home here is when they set out to randomize everybody, they actually found as the majority of the people found in the study, the predominants were male. And in addition, the predominant ethnicity of the population within the study were actually white. Next slide. So table 2 discusses the overall outcomes that the group went to look at. And what they found is in the gabapentin group compared to placebo group, that when corrected both for heavy drinking days as well as no drinking days, their secondary outcome with percent DCDT corrected, there was a statistically significant reduction in overall drinking, or a higher level of no heavy drinking days, or a higher number of no drinking days. in the gabapentin group as compared to placebo. Next slide. So in their second figure here, they were essentially trying to look at if the percentage of individuals with heavy drinking days or no drinking days during the study. And they further broke it down with patients who had either a high alcohol withdrawal score or a low alcohol withdrawal score. And they found here that patients who had a higher alcohol withdrawal score actually had a higher degree of both no or no drinking days or no heavy drinking days, versus looking at patients who had a low alcohol withdrawal score. They tended, when they were treated with gabapentin, they trended along the similar findings of that with placebo for both low alcohol withdrawal score and high alcohol withdrawal score. And further sort of teasing this out on the next slide, table 3 is reporting gabapentin versus the placebo treatment on various drinking variables, and again, breaking it down based off of low versus high alcohol withdrawal score. And what was found here is in the gabapentin group versus placebo, there was actually more, there was a improvement with gabapentin versus placebo in more or a decrease in overall heavy drinking days and more percentage days abstinent when treated with gabapentin, particularly in the high alcohol withdrawal score group. However, they found that it did not decrease drinks per day or drinks per drinking day. So it trended more towards the patients with the higher alcohol withdrawal score. Next slide. And of course, as I mentioned earlier, during the medication or the medical evaluations of the patients throughout the study, they did record this safety profile on all of them to look at adverse medication effects. And what they found was that there was significantly more dizziness, described as being mild to moderate, in the gabapentin treatment group. And there was also more within individual reports of nervousness and headache within the gabapentin group, and more within individual reports of insomnia within the placebo group. Next slide. So some limitations overall in the study, that there was a large number of participant dropout, as we saw in the consort diagram previously. Also, this included individuals who were more predominantly white and male, so it's not necessarily fully generalizable to other groups. And this also excluded more of our alcohol, our sicker alcohol use disorder patients, including those with higher alcohol withdrawal scores and those undergoing active alcohol withdrawal. It also included those who have alcohol use disorder who might have transaminases greater than 3, as these patients were actually excluded from this study as they were deemed not medically stable. Next slide. So in conclusion, gabapentin may be helpful in sustaining abstinence or decreasing heavy drinking days in patients with alcohol withdrawal symptoms, particularly those with more severe alcohol withdrawal symptoms. Future directions could include increasing the inclusion criteria to include patients such as those with elevated transaminases, and performing analysis within specific cohorts, and additionally broadening the overall diversity of the group to include other or a better generalizability as opposed to just a predominant of white males. They can also look at symptoms related to protracted alcohol withdrawal symptoms as well as the possible effect of gabapentin on patients who do complain of protracted alcohol withdrawal symptoms. And with that, I think we can open it up for discussion.
Thanks so much. That was a great review of that paper. So again, audience, if you would like to make a comment, drop it in chat. If you'd like to speak, just raise your hand. We'll be happy to get you in on the conversation here. Yeah, I think it's a great paper. My question is, what's the next step from here? I'm not sure that I'm going to prescribe this as an ER physician. I wonder, is the next best place to study this after someone's been stabilized in the hospital, discharged? Will primary care folks be more comfortable using this in this patient population? Is it addiction medicine folks? I don't know if you guys thought through where you think the next population to study this would be for.
So I think I'd like to see, again, like I mentioned before, just a little bit more generalizability within the patient cohort. And I think I agree. I think this is probably not something I'm going to start right now in the emergency department on patients. That being said, I think the overall safety profile of gabapentin is pretty good. And those patients who are reporting higher levels of alcohol withdrawal scores in the past, there could be some benefit as shown by the paper. So it could be something to consider, but certainly I think it's something that the primary care folks could really consider even beyond or earlier than those of us in emergency medicine.
Yeah, and that makes sense. And I think that we did hear from one primary care doc at our institution that is already using this. So I was interested to hear that. We have a comment here. How are they able to protocolize gabapentin dosing considering they noted adverse effects from it and would have benefit to compare doses rather than escalate?
Yeah, so they looked at complaints or adverse effects in general, and it wasn't unblinded until after the study. So they reported on patients who complained of adverse effects from both placebo as well as those who were receiving gabapentin. So it was more of the medication side effects that we were seeing with gabapentin versus what sounds like in the placebo group, as you would expect, there was a higher incidence of insomnia, which is one of those sort of protracted alcohol withdrawal symptoms that's been defined previously. So they sort of just took an overall encompassing look and then unblinded it at the end of the study to see what effects were where.
Great. Oh, and I actually appreciate your comment, Dan Replinger, that they're using it gabapentin as a second line agent. So that's definitely very helpful. And then let's see, one more comment. Conclusion mentions that you would consider this especially for those with severe symptoms. However, they excluded patients with a CWA greater than 10. Yeah, any thoughts on that?
Yeah, so I actually didn't like that they excluded patients who had higher CWA scores. And I think the reason for that was that they were just being acutely managed for their alcohol withdrawal. But for patients who do at least report having higher degrees of alcohol withdrawal based off of the alcohol withdrawal scores performed in their analysis in this paper, it seemed to be more compelling that this seemed to have a higher degree of impact for both abstinence as well as decreasing heavy drinking days. So for those patients, based off of this paper, at least I think it's reasonable to consider, but I think a future direction is definitely to look at even starting gabapentin earlier on in alcohol withdrawal treatment protocols for our sicker patients and those who do have CWA scores of greater than 10 or do even report a history of alcohol withdrawal seizure.
Yeah, excellent. And yeah, I appreciate Todd Phillips' comment here. They treated it for over 100 days. Is there an endpoint? Or do they suggest they take it forever? So clearly, we need studies to define that. I don't think we really, have enough information to know the endpoint there.
Yeah.
Okay, well, there's a few more good comments in the chat, but why don't we move along to the next paper?
Okay, so thank you, Chris. Great job. So the next article will be presented by Mohammed Jeffrey, who's our first year fellow, and he will be presenting the article from Pittsburgh titled Adjunct Ketamine Use in the Management of Severe Ethanol Withdrawal. It's all you, Mohammed.
Awesome. Hey, everyone. All right, next slide. So just some background regarding this. The study had mentioned that there's a 10% of admissions are complicated with ethanol withdrawals. And they noticed that a third develop severe withdrawal, and that ultimately prolongs hospital stay and costs. And we've all seen that happen. Next slide, please. And so a subset was noted to still develop severe withdrawal even after being given GABA agonists. And so a treatment of ethanol withdrawal really was noticed to focus on GABA agonists, so benzodiazepine and barbiturates. And so this study is trying to focus or add ketamine, which we all know works as an NMDA receptor antagonist. which is also comparable to how ethanol works. It works on both, agonizing and antagonizing both receptors respectively. Next slide, please. And so the objectives of the study was the use of ketamine as an adjunct in the treatment of severe alcohol withdrawal, such as delirium tremens, to improve the outcome. Next slide. So the methodology, this was a retrospective observational cohort study. And this was an academic tertiary care hospital in Pittsburgh. The inclusion criteria, they have to have been admitted to the ICU. They needed a diagnosis of DTs, which is either made by the toxicologist or a critical care physician. And they needed complete medical records since this was a retrospective study. Next slide. So they had it separated in pre-guideline and post-guideline. So the pre-guideline, so before they introduced ketamine, they had it extended from January of 2008 all the way to March of 2011. And then during that period, they would administer benzos, either diazepam or diazepam equivalent, in a symptom-triggered fashion. And the dosing was based on the withdrawal assessment scale. And it was basically greater than 10 or whatever the bedside physician felt like the clinical evaluation. And that was their endpoint of giving, when to stop giving benzodiazepine, greater than 10 or more. And if they are intubated, once they're intubated, then they would add propofol and or dexmedetomidine in addition to benzodiazepine. So if they're not intubated versus intubated. Next slide, please. And then from April of 2011 to January of 2015, they had their post-guideline where they introduced ketamine. And they did anywhere between 0.15 to 0.3 mg per kg per hour as an infusion. So once they saw that they had DTs, they immediately started the infusion of ketamine. Some of them may have given a bolus initially, depending on how agitated they were, and the bolus was always 0.3. And so that was not really standardized. It's just based upon the clinical judgment or bedside assessment of the clinical toxicologist or the intensivist. And then they went back to also, in addition to using the same sort of GABA agonist dosing of diazepam or similar milligrams in a symptom-triggered fashion. Next slide, please. And so the results, so they had 63 patients total included in the analysis. 29 were pre-guideline and 35 were post-guideline. Next slide, please. And so this is the results. You had the mean, which is no ketamine versus ketamine. You had primary ICU admissions, and you could see quite a few traumas there, and just pretty much withdrawal as a diagnosis to the ICU. And the rest is sort of just GI and elective. Next slide, please. And so ketamine was associated with a significant decrease in ICU stay, P of 0.043. And there was a decrease of 2.83 days on average. And there was also a decreased likelihood of intubation. However, that was a regression sort of analysis. And the P was less than 0.01. And so this table, I really like this table, sort of summarizes everything very well. You had the outcome in patient with severe ethanol withdrawal who received ketamine versus no ketamine. And so you could see with no ketamine, the ICU stay was all the way up to 11 days versus 5.7, pretty dramatic decrease in my opinion. The mean benzodiazepine use, significant as well, 0.02, mean, hospital stays was less. Um, Intubations, again, it was a regression sort of analysis and statistically significant. Propofol use was not statistically significant, but you could see that compared with no ketamine versus ketamine, 20 versus 9, and it makes sense. Propofol does have some NMDA activity, so, but not statistically significant. So yeah, very interesting study results. Next slide, please. And so these are the details of the ketamine. So they talked about how ketamine loading dose and the infusion, which is averaged amount 0.24. So it makes sense for anywhere between 0.15 and 0.3. And the duration, they also talked here showing you the benzodiazepine use and pre-ketamine and since ketamine. And finally, total benzodiazepine doses given. Next slide, please. So what are the limitations? Quite a few. So it's not randomized or blinded. The WAS score was used subjectively in different scores. Ketamine boluses were provided, so it wasn't really standardized on who got what and when. They did use propofol and other sedatives, so there could be a little bit of misinterpretation if you're using propofol and ditching ketamine, whether it's propofol that's doing the heavy lifting or ketamine was. And the primary admission to the ICU, there were other diagnoses and admissions. So if someone had a severe trauma, it could lengthen the ICU stay. So it's hard to say if it was ketamine that did it or not. And primary admission to the ICU may also alter the outcome. Next slide, please. And conclusion. There is an associated decrease with ICU length of stay, which I feel like is a major point to the study that shows it. Ketamine infusion was associated with fewer intubations, and definitely future we'll probably do a prospective double-blinded study which show how great ketamine is. That's it for me. Questions?
All right, well, awesome. That is a great paper, and I know that we've probably all read this one in our journal clubs. I did ask Tony Pizon to join us, and is that you on Pittsburgh Talks? Not sure if you could raise your hand, Tony, that would be awesome. Let's see, moving Pittsburgh Talks up. Let's see if you can join us as a panelist. And also, again, please drop questions, comments into the chat. Great, and I agree with you. I thought table 2 is definitely the big, big outcome shot there. Oh, is that you there, Pittsburgh Talks?
Yeah, can you hear us, Steve?
Yeah, great. Thanks for joining.
Oh, my pleasure. It's an amazing study.
Landmark, I would say.
Landmark. No, you know what? It obviously is very limited because it's retrospective and we use historical controls, but we wanted to kind of demonstrate what we kind of sensed back in the day. The typical mojo for our sick withdrawals that we got consulted, say a trauma patient that was there 4 or 5 days, then went into bad withdrawal, and we flogged them with benzos or barbs for 4 or 5 days. And then 4 or 5 more days after that, they're in benzo and barb delirium. And then 4 or 5 more days after that, they're deconditioned. So it's sort of like a 3-week hospital stay. We kind of recognize we completely ignore NMDA. So why don't we add NMDA? And we had noticed that we were using ketamine. That ketamine really decrease your barb dosing. They get better a lot quicker. You're sort of augmenting what maybe another receptor that you can treat them. And we had like a lot of success. And unfortunately during the study, as was pointed out, we were still trying to navigate what our dosing would be. We started off with some of the pain literature dosing and quickly ramped it up, and we're occasionally using boluses and so forth. So yeah, that's reflected in the paper that we kind of use that time to navigate and determine like what's the best dose right now. But pretty much it's 0.3 milligrams per kilogram per hour for the first 24, then we cut it in half until they're better. And usually they're on the half dose for like 2 more days after that. And we rarely use the bolus anymore, because normally we're bolusing them with barbs or benzos early on to get them sedate, and then we kind of just use the ketamine to keep them there.
Yeah, that makes a lot of sense. One thing that really jumped out to me that, was brought up already was on table 2. You notice like the different cocktails had different effects in terms of intubation. I really found it fascinating how when you combine propofol with benzos, even though it was statistically significant, they're more likely to get intubated than if you're using ketamine. Again, you were at the bedside for probably a lot of these cases. Was that, is that how you saw it?
Yeah, I mean, the beauty of ketamine is, people don't lose their airway. That's great. I mean, and I know it's a little bit jaded. Once you're into, and that may be sort of the bias in the paper. Once you're going down the route of intubation, putting someone on propofol, you're kind of like, heck with ketamine. You don't even think about it. You're like, oh, just put them on propofol and shut them off. So that may be a little bit, I don't know, it doesn't really represent the issue, but we feel like if we get somebody early enough, get them on ketamine, avoid like super high dose of benzos or barbs, then you can really avoid the intubation, which makes, I think, the exam a lot easier too, in terms of treatment and not over treating them. So.
Yeah, no, I would definitely agree. Let me reach out to Todd Phillips. I don't know if he wanted to make a comment.
Oh, did I raise my hand accidentally?
Oh, no, sorry. That's okay.
That's okay. Well, I was going to type anyway to Benjamin Crewley's point. I was kind of looking at it. He said that it was noted that there's length of stay decrease. And it may be due to benzodiazepine sparing, because as Tony said, and I was at Pittsburgh when we were using this, and we would see these benzo delirium. They would stay 4 or 5 days in the deconditioning. That was a real thing. But that's a good point that he brings up, that the decrease in benzodiazepine might have prevented that length of stay prolongation. But I kind of we always compare ketamine to Presidex or dexmedetomidine, because that's probably much, much more commonly used as an adjunctive therapy. And the dexmedetomidine studies, some of them have showed that they've decreased the benzodiazepine usage as their primary endpoint, but then their secondary endpoints do not change the length of stay. So it is a good thing that they do decrease benzos, but it doesn't change the length of stay, where ketamine does. So you think that adding that anti-NMDA might have an additional benefit than something like what Prestex does, with just more sedatium. It doesn't treat the primary cause. So that's all I gotta say.
Great. Thank you. No, I think those are all excellent points. And, I do think there were the dexmedetomidine, I guess, was present in 12 cases here. And again, so I like Suzanne Dionne's comment here that, this is a retrospective study and there are definitely selection bias. So, we have different clinicians choosing a treatment model. This is definitely not an RCT. And I think, we would all love that. I think, we've talked about this within our group. The difficulty of pulling off an RCT is really huge. Kevin Osterhout has an interesting question here. Dextromethorphan has been studied in many brain applications. Can you see a role for early DXM in some of these patients? I guess I'll throw that out to you guys.
I mean, that's a good point. I mean, we still use ketamine for our sicker withdrawal patients, because usually you can give, the other patients, meandering dose of benzos and they get better pretty quickly. But we thought about using, ketamine even for the less sick patients. Maybe that will help them as well. So that's a good question. I don't know the right answer to that.
Yeah. Thanks, Tony. Yeah, I think, being able to use IV ketamine, which, the off time, when it'll happen, makes it a little bit easier. But that is an interesting thing to think about. All right, awesome. Okay, any other comments or questions here?
Yeah, actually, Steve, it's Gina.
Yeah.
Tony, thank you for calling and thank you for all of your insight. I just had one question. Have you considered doing another study over a longer time period where you look at patients just with a primary diagnosis of alcohol withdrawal?
Yeah, and as you'd mentioned, and I think Suzanne had mentioned too, this retrospective study, kind of has a lot of bias and so forth. Yeah, my problem is I've had a hard time trying how to implement a good prospective study in this regard, maybe pure withdrawal or whatnot. But I just have not cut off my hiney and done so. It's just been a challenge because there's so many, as you know, with withdrawal treatment, so many different cooks in the kitchen, how people want to treat it and so forth. It's been difficult to navigate what the next steps would be, but prospective study would be absolutely the next best thing, Gina. You are absolutely correct.
I completely understand. Thank you.
Yeah, I think organizing a prospective study, it's out of our sphere of control for a lot of the care of what's going to happen out of the ED and up in the ICU. So it would require a tremendous amount of work to get off the ground, but would be worthwhile. Okay, all right, well, thank you again for the comments. Why don't we move on to the third paper?
Okay, so our third paper will be presented by David Loughran, who's one of our first-year fellows, and he will be presenting the article titled Benzodiazepines versus Barbiturates for Alcohol Withdrawal, Analysis of 3 Different Treatment Protocols. So David, you can go ahead.
Hello, everybody. So this was a paper out of Denver Health, and it was accepted in 2019 in the American Journal of Emergency Medicine. And we can go to the next slide. So the background for this paper is somewhat similar to the others. They point out that there's a massive population of patients at risk for alcohol withdrawal. And again, in-hospital management is time-consuming, resource-consuming, and potentially a large burden for the healthcare system at large. There is no good consensus for the best drug, the best dose, or even the best route of administration. And then unique to this study is the fact that it was sort of brought about by a drug shortage of diazepam. And so they point out that drug shortages intermittently require adjustment of protocols for institutions. We can go to the next slide. So certainly this is not the first study written about this topic, and you could probably fill a book with what's been written about comparing barbs and benzos. We can go to the next slide. And the next one after that. And then the next slide. So in this study, so their objective here was describing the effectiveness of these 3 different alcohol withdrawal protocols that were utilized during different time periods, basically due to the shortage of diazepam. So they were all IV medications. There was a diazepam only arm, a lorazepam plus phenobarb arm, and then phenobarb only. Go to the next slide. So this is a single center retrospective observational cohort study. It used a convenience sampling of 100 consecutive patients in each protocol. And down below, you can see the inclusion-exclusion criteria, fairly basic. The exclusion criteria was that a patient would have no documented withdrawal score and receive no treatment. Next slide. So these were their time periods and the associated treatments. So you can see the phenobarb only study was a relatively short period here, as was the lorazepam and phenobarb, and diazepam was closer to half a year. And then below that, in the figure 1 in the paper, is this example of the phenobarb containing protocols. So it's a little bit confusing, but you can see in the darkest box is there. This is the SEWS score, which was an institutionally validated, like internal withdrawal score that essentially uses symptoms and scores 0 if not present, and then a 1 or 2 or 3 depending on the symptom, and then they classify them as mild, moderate, or severe. And then the different treatment modalities over different time periods that obviously all contain phenobarb. And this is just an example of their protocol. Next slide. So they had their primary outcome was rate of ICU admission from the ED. That was their main question. And then they had a variety of secondary outcomes that you can see here, and many of them revolved around the idea of length of stay or ICU admission, and then drug dosing, and then there's this extra sort of interesting secondary outcome of protocol violations, and we'll get to that in a bit. Next slide. So this is table 1. It's essentially their baseline characteristics and demographics of the study. And you can see over on the right, all the p-values are not significant, suggesting that this was a fairly well matched cohorts despite being at different time periods. And I do want to point out specifically the primary diagnosis of alcohol withdrawal syndrome is relatively small in each group, suggesting that these patients were admitted for various other reasons similar to the study prior. And we see this, and I'm sure you all see it as well, trauma patients and being admitted for other reasons, and then developing alcohol withdrawal. And next slide. And this is table 2. So this is their outcomes, and this is really the meat of the study. Just pointing out some of the statistically significant p-values up here in the right-hand corner. So they found a 19% increased rate of admission for the phenobarb group alone, and then compared to the other 2 groups where they found no difference between diazepam only and lorazepam plus phenobarb. And then overall length of stay was lowest for the combination group, and then the average length of ED stay specifically was lowest for the diazepam only group. And next slide. And then in the bottom right-hand corner here, the other statistically significant p-values are in the dosing of drugs, so diazepam equivalents and phenobarb. And I'm not sure that these are particularly relevant because they're comparing groups that are supposed to not contain, phenobarb or not contain benzos if it's the phenobarb only group. So those p-values are always going to be very low. I do want to point out though that in the phenobarb alone group, some diazepam equivalents snuck in here and contaminated those results a little bit. Next slide. So conclusions from those statistics. So they found that the use of phenobarb was not associated with an increased ICU admission rate. The use of phenobarb was not associated with need for intubation, and in that prior chart, the N values for those were very, very small anyway. And then the use of phenobarb was associated with decreased benzo consumption, which makes sense, and that's a lot of what the literature suggests and touts barbs as being a good adjunct for. And then the use of phenobarb alone was not associated with, or was associated with an increased risk of rate of hospital admission. And we can go to the next slide. So their ultimate conclusion was that phenobarb seems to be safe and effective in alcohol withdrawal syndrome, which I would say is not outside of what much of the literature already suggests. And then the next slide. Some of the limitations here. So it's again a retrospective observational study and comes with the limitations associated with that form of research. This was they used a convenience sample of the first 100 patients per each treatment arm, which is an interesting choice, and I think comes with some inherent risk of bias, and is relevant to the next point, which is that in the phenobarb group, that increased rate of hospital admission may have been due to provider, familiarity or really lack thereof with phenobarb. So if you're giving phenobarb and not really quite sure what to expect, you're probably going to be more likely to admit those patients. And they also point out at the end of the study that the phenobarb group was one of the most sort of rushed protocols. So the education was not as, the provider education before instituting the protocol was not as robust as the others. And then the violations in the phenobarb group that were pointed out on the table 2 has the potential to introduce uncertainty of its effect or efficacy. And then again, having a primary diagnosis for admission other than straight alcohol withdrawal probably introduces some variability in outcomes like length of hospital or ICU stay, sort of similar to the ketamine study prior. And next slide. I think that's it for me.
All right, great. Thanks so much. That was a great summary. And again, please drop some comments into the chat. And if you'd like to talk, just raise your hand. That'd be awesome. Yeah, this is a fascinating paper. And, I guess the way I read this is that this kind of came on the heels of the diazepam shortage and really looked at, can we really roll out the phenobarbital, in the ED setting? I still am find it stunning that they were able to recruit all the phenobarb cases in such a short time period. So I just kind of wondered, what happened in their department that made that that operational. And then I guess so we got a comment here. There's a trend from Sarah Weiss, is a trend toward higher withdrawal scales in the LNP and P groups where they didn't address and may also account for some of the difference in admission. Yes. I guess a question from phenobarb to you folks. I know we've debated this point a lot of symptom triggered dosing of phenobarbital versus, some folks are calling for a loading dose. I'd say as an emergency medicine person, I'm definitely a big fan of the symptom triggered. And also, I think the variability in what actual requirements are, and given that you may cause sedation with a full load of phenobarbital, I think that that's an argument towards just symptom triggered escalating dose over time. Do you folks at Rutgers have a specific approach to that?
So we do have a guideline that we use hospital wide. We developed it and got really kind of got buy-in from our ICU or medicine service. So it is used generally kind of across institution. So we actually use a RAS scale just because of the simplicity of using it versus the CUS scale. So our goal RAS is about 0 to -1. When patients actually arrive, if they're able to take PO, if they have a RAS less than 3, we start off with PO chlordiazepoxide. And then we give them the chlordiazepoxide, reassess within an hour, redose if necessary. If the RAS is greater than 3, then we use the IV diazepam or IV lorazepam. And we escalate that, double the dose. And then when we reach the threshold of about 200 of the diazepam or 40 of the lorazepam, then we convert to, then we switch over to phenobarbital, 65 milligrams, essentially every 30 minutes, really again, looking for that goal RAS of 0 to -1. And if that doesn't work, then of course, then propofol is, we start thinking about other modalities such as propofol.
That's super interesting. So then you folks use kind of a diazepam resistant dose protocol for your sicker ones and then switch to phenobarb at that point. Is that right?
Yes, yeah, that's what we do.
Okay, great. Yeah, and again, if anyone else has a different approach, it would be interesting to hear that. Do you have any problem now with shortage of diazepam, or is that not an issue at your place right now?
That's not an issue at our institution right now.
Okay, yeah, because we, at Cook County where I work, we do not have access to diazepam still. That's interesting. All right.
So are you, Steve, this is Diane, are you think moving to earlier phenobarb or just alternate benzodiazepines?
Yeah, again, this is more in the art realm as opposed to the science. I think that there's adequate literature to support using phenobarbital early. I think like in our tox group that works, in emergency department as well as in toxicology, I think we've been making a point of, getting our residents comfortable with phenobarbital because, it's just fascinating talking to our rotating residents. Many of them have never even heard of using phenobarbital for alcohol withdrawal, when an old thing becomes new. So we don't have a specific protocol the way you do, which I actually think is a good thing. but I think many of us are using it earlier, more so that our trainees will have comfort for it. I think it's one of these things where we know that both pathways are effective, but yeah, so that's been our approach. We're seeing a couple other comments here. Again, Kevin, I appreciate your point. So the Rosen study supports loading dose phenobarbital with moderate to severe withdrawal. What I find interesting about that is, how do we select the patient that needs a full loading dose versus symptom triggered specifically in the ED? So I think that's still a question in my mind. I'm not sure about. And then the folks at Einstein, they've been trying to move phenobarb up earlier in the management of severe withdrawal, and they're having, I guess, a good experience. So that's interesting to hear. All right, and I think this is such a great topic, particularly, where do we put phenobarbital in an old drug into our algorithms? I think we'll all be looking forward to more study. Yeah, and I agree with what Einstein's saying here. Lots of fear about the drug among other physicians here, though. And I think, when people have not used the drug before, they don't have comfort with it. And I think in our toxicology community, I think that's not an issue. So, it is interesting. I think we do, it's incumbent on us to get more of this in the literature and have pathways that demonstrate safety and efficacy. Great. All right, so we're heading towards the top of the hour. Do you folks at Rutgers have any final wrap-up comments?
No, yeah, they just thank you everyone for joining. I think as somebody had mentioned earlier, gabapentin, I think we need some more studies, but it has a pretty good safety profile and something to consider in the outpatient setting. We're not currently using ketamine, but Pittsburgh, we really liked your study, and definitely I think we're more amenable to using that ketamine, especially in the ED. I think a lot of it also is just kind of getting buy-in institution-wide across different services, but definitely something to consider and something we may think about using in the future.
Awesome, I totally agree. Okay, so I'd like to thank Gina Jacob, David Logren, Christopher Meaden, Mohammed Jeffrey. Thank you. It was a fantastic presentation discussion. Our next National Journal Club will be July 13th, lucky 13th, 2021, and it'll be presented by Heather Borick and the team at University of Virginia. I would just wanted to thank everyone for tuning in, and any comments on format, please feel free to reach me. And PDs, we're still looking for some folks to schedule after September. So with that, thanks so much, folks at Rutgers, and we'll see you next time.